You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
This podcast is brought to you by Carl Zeiss Meditech. The authors/speakers have a contractual or other financial relationship with Carl Zeiss Meditech AG and its affiliates and have received financial support. Products, services, or offers referenced in this video may not be available in all countries, and product labeling varies by country.
So excited to be here with my friend and colleague Nandini, another Smile aficionado. And we're going to be speaking today about getting started with Smile and how you go ahead and do that. We are both consultants with Zeiss. I always like to start with some words of wisdom, and this is actually from Rohit Shetty's Institute in Bangalore in India. And one of my favorite sayings is the most dangerous phrase in the language is because we've always done it that way. And it's really important to keep this in mind whenever you are thinking about something. People get into their comfort zones and they are afraid to try new things. However, it's really important to try new things and think outside the box, think outside the flap, and remember that the most dangerous phrase is because we've always done it that way. And with that, for those of the beginners, we'll go ahead and explain the cuts here, and Nandini will elucidate some of this for you.
Yes. So yeah, absolutely important to kind of think outside the box. The beauty of Smile is that it's using a femtosecond laser to create lamellar dissections in the cornea. You're seeing an animated video here. And then in the next slide, you can see how that laser starts to make those lamellar cuts. So this first cut that you see that's going from the outside in is known as the refractive cut. It's defining the depth of the lenticule and the actual refractive power of that lenticule. There's a side cut that's made subsequent to that. You'll see here, and then there's an anterior cap cut. That's going to identify the anterior aspect of the lenticule. And these different cuts are going to be what helps us identify where to dissect during the course of the procedure.
And the great thing, which we'll go through, is what the brand new Smile Pro laser with a Visumax 800, this is all done in less than 10 seconds.
Which is amazing.
So why Smile? Well, I just had to show a really cute animal photo here because who doesn't love a cute animal except those of you who might be dislike cats. What do we talk about when we talk about any procedure ever, any surgical procedure? What do patients want? They want two things. They want great outcomes and they want safe procedures. And that's what we can deliver with the Smile procedure.
And I think the literature really shows that. You know, there are equal outcomes with LASIK, PRK, and Smile. So when patients are coming in asking me which procedure do I recommend, as a Smile surgeon, I have the confidence of the literature to say this is a procedure that delivers. And there's been a recent paper out in JCRS that shows that within the military population, you're seeing fantastic outcomes of safety and efficacy across all three procedures about 6 months postoperatively. And so that's wonderful. These are patients that really need the precision outcomes delivered, and we can produce that with Smile.
I think that that's important, especially for beginning surgeons, because you may be in your LASIK comfort zone, and why would I do another procedure, and what about Smile? What have I heard about Smile? This article is a great article, and really it looked at thousands of patients and showed that the results are equivalent among Smile, PRK, and LASIK. Not only that, but if you do a little deeper dive into the article, the 1 month and 3 month results showed that actually the Calyx or Smile procedure actually had better outcomes in terms of visual acuity compared with the PRK. So why Smile? Why did you transition to Smile, Nandini?
Yeah, I think patients came in asking for the procedure, and as I was looking at the literature, things were really compelling. One was the fact that this was a flapless procedure. So what other flapless option do we have? PRK, but there's longer healing. There's some risk of haze. But here I can use a femtosecond laser and create those lamellar dissections, and I don't have to create a flap for that patient to get an equivalent outcome. Also, dry eye. I think ocular surface disease is so prevalent now, and I myself have dry eye, and if I'm having a procedure done, I want to make sure that that complication does not get exacerbated. And I think that's one of the interesting aspects of SMILE as well.
When we look at the features of the Visumax, it's currently the only femtosecond laser approved by the FDA for the SMILE procedure. It's very comfortable for the patient. It's low. Basically, because you're using low suction, you're not having that sensation of patients sometimes feel like their eyes getting sucked out of their head, that like dramatic, very dramatic suction because it's low suction. And that makes it really, really comfortable for the patient. So what's new in 2025? What's new with laser vision correction? Well, the really exciting thing is the SMILE Pro for lenticle extraction. Again, shorter treatment times in 10 seconds. There's also an independent bed, so there's a smaller footprint. I actually have a new laser center that I'm opening up, and I have the great marriage of the Visumax 800 and the Mel 90, but because of the small footprint, especially with opening up and having limited space for my laser suite, I was able to fit both in easily. There's also ocular alignment for astigmatism treatment, for central alignment, cyclotorsion adjustment, and this is, let's see if we can get the video to play here. Here we go. And this is the actual treatment, okay? So you can see that we're just lining that up there. And there's actually, you can see with the Oculine, you can actually get that centered really nicely. There we go. We've got the suction. Those two blue rings show you there's suction there. And this is the actual time of the treatment. This is not sped up at all. We have the posterior, now the anterior lamellar cut. Don't blink, and it's done. And that's what's really great. Most of the suction breaks that we've seen with the previous generation of lasers occurred in the last 10 seconds, so during the anterior cap formation. So by having this only 10 seconds, less than 10 seconds, suction breaks are so much less frequent.
Absolutely. And I think also one thing with the cyclotorsion is, the beauty of accounting for cyclotorsion automatically with the new Visumax 800 is fantastic. Previously, what I would do is actually mark at the limbus with a marking pen and then slightly turn the interface to ensure that I've accounted for cyclotorsion. But again, that could potentially contribute to suction loss, can cause that procedure to be a little bit longer. Here you can see how quickly that procedure is being done seamlessly, and I think that's one of the really exciting aspects of the new laser.
And you can just Z in on your alignment here, and that's what that shows.
So how do we get started? And I think that it's always important to think that a single step is what's going to help you get started on a journey. And if you prepare yourself and you kind of educate yourself on how to be successful with the procedure, I think that you can incorporate SMILE very easily into your refractive practice. I think to be a comprehensive refractive surgeon these days, it's really important to have SMILE in your toolkit.
And also the nice thing is that Zeiss as a company really has a lot of resources to help you be successful, whether that's with their clinical ops, their engineers, all of the team really helps to make sure that you are successful when you go ahead and you start doing the SMILE procedures. They set you up with mentorship, they set you up with the engineering team, they help you with the marketing team, and so basically they have a very comprehensive program for helping you get started with the procedure.
So what are some practical considerations? I think first and foremost, pick the right patients. And I think friends and family are great people to start with. You have a new exciting technology in your practice. Ask if some of your technicians are interested in having the procedure. Close friends, family members of technicians. And this way you get the opportunity to try this procedure, get fantastic outcomes, and then they're going to be such wonderful advocates for the procedure in your practice. The best thing is when someone in my practice has had SMILE, and when they talk to a refractive candidate, they're like, hey, I've had this procedure too, and I'm able to see 2015, 2020, and that goes such a long way for patient recruitment.
I think those are really, really great points, Nandini. small incision lenticle extraction. It is approved between 0.75 and 3 diopters of astigmatism from -1 to -10. I'd say a pro tip is start with the rule astigmatism because the lenticle then will be thicker, okay, with the rule direction versus against the rule. Also, about a -4 for your first 20 or so cases. Just make life easier for yourself. I like life to be easier. I like things to be easier. Why make it more difficult? And so I think these are things when you're getting started. Once you're established, of course, going down to a -1, especially with the new Smile Pro laser, is not a problem. But when you're first getting started, you want success. And so you want to build upon that success and confidence level. Residual bed, technically it's greater than 250 microns. I think that there were some nice recent studies that actually showed the strength, okay, looking at the analysis of the strength of the residual bed. And with Smile, you actually can go a little bit lower than LASIK. LASIK, I always leave about 300. For Smile, I actually will go down to about 260 to 270. And they showed that about 270 to 280 is really the same as PRK. So that's great to know.
Absolutely. And I think one thing we had on the previous slide is importance to know your laser and your nomogram. So if you have other surgeons in your practice that are also doing Smile, working with them to adjust how you're planning your refractive treatments is very important to get those excellent outcomes.
Absolutely. Well, let's talk about some common issues that people have concerns with when starting Smile. And I think these are centration and also identifying the surgical planes.
So when you're starting off learning to do Smile, I think the biggest thing to understand is where you are in the aspect of your dissection, to understand your anterior cap and the posterior refractive surface of the lenticule. So Susan Jacob has described the white ring sign, which I use all the time during my procedures, and it's very intuitive. The laser is going to reflect a ring of light along the edge of the lenticule side cut. So you should always keep an eye on where that ring of light is in relation to your instrument. So if that instrument is actually obscuring that ring of light, you know that you're anterior to the lenticule. If that instrument is underneath the ring of the white light, then you know that you're posterior to the lenticule. So as you're using your Sinskey hook to open up your incision, or as you're using your dissector, if you constantly look at the relation of the ring of white light and your instrument, you really can know confidently if you're anterior or posterior. Because one of the most common things we see with beginning Smile surgeons is not being able to confidently know which side of the lenticule they're on.
Yeah, and sometimes you think, oh, I can't find the posterior plane, but actually you are already posterior. That's okay. There's some surgeons that actually dissect posteriorly first and then go anterior. I like anterior first and then posterior, but sometimes even now I'll say, oh, I think I was anterior. Oh, no, actually I was in fact posterior. Not a big deal. You can then go ahead and dissect anteriorly.
Yes.
The program is brought to you in part by Carl Zeiss Meditech, a global supplier of medical technology solutions for ophthalmic providers and their patients. For additional information, please log on to the Zeiss Professional Education iTube channel.
And so this talks about identifying interface planes, and I slowed this video up here so that you can actually see. You can lift up to be sure you're anterior, and what I did is we slowed it down so you could actually see the white line.
Yes.
And here we go. This is what Nandini was discussing. You kind of wiggle that in there posteriorly, and then you can actually see that white line, and that white line is in fact above the posterior section. So what I do is I like to start out making that little box, do anterior, then do posterior, and then continue the dissection until you are actually under where you were anteriorly, and you'll feel resistance. And that way you know 100% you're in the right place.
I think it's also very much a tactile procedure. As you're in there dissecting and kind of identifying your anterior plane, you feel that sense of continuity along the anterior aspect. And when you go to identify your posterior plane, you'll feel a little bit more resistance from side to side. That's what helps you know, okay, I'm posterior. And then those visual cues as well. So as you're learning, you're kind of putting together your tactile feedback and your visual cues to help you understand where you are in the course of the dissection.
And the nice thing is now with the new Smile Pro laser is that it's even easier. The lamellar dissections are just beautiful. It's so much fun. Even for doing some of the lower myopes, I used to struggle a little bit actually when it was a low myope, minus 1.75 or below. You'd feel a little bit of reticence, a little bit of stress there. But now the lamellar dissections are so much easier that you can feel confident that you can even do those low myopes. Although to start out, I would still recommend doing the mid myopes.
Yes, I totally agree. So what are some considerations for lamellar dissection? So when you're looking at your patient, you want to obviously understand what their refractive error is. Also keep an eye on their corneal pachymetry. That'll come into account when you're thinking about how much residual stromal bed will you have after your smile lenticule. And like we mentioned before, every laser has an ideal energy. And so your Zeiss rep is going to really help you calibrate that laser, make sure that it's working to the best of its ability that it can. But many times, if you have a thicker cornea, so in your beginning cases, look at those pachymetries. If they're thicker corneas, you're going to want to potentially increase your energy by one step for all laser cuts. And that's something that's done in expert modes. Your laser rep will help you understand that. But this is going to help titrate how smooth those dissections can be because of where you are in the stromal bed.
In the anterior lamella, when you're more anterior, so if you have a thicker cornea and you have a 120 cap, right, you're still going to be more anterior compared with if you have like a 530 micron cornea with the same 120 cap, you're going to be further into the cornea. We know that the anterior lamellar are more densely packed, and that's why with a thicker cornea, because you're actually more anterior relatively, you're in those densely packed lamellar, and so the dissection can be a little bit more difficult. That's why you could consider bumping up the energy, and by bumping up the energy there, you're just going to make that dissection a little bit easier for yourself. Remember that then you want to decrease the energy for your next case. Also, you want to get a sense of your own laser suite. Different locations are going to have different, your different laser in a different location. My laser in Seattle is going to be different from Nandini's laser in Boston, which is going to be different from a laser in Denver, Colorado. And so for each laser, they'll be tuned to their own energy, and that's important to really know how your laser is running each day.
Yeah. I think we went through that, just understanding the anterior stroma has those dense, lamellar fibers, so the improvement with higher energy can help with the dissection.
The higher the refractive correction, the thicker the lenticle, and so it's actually easier to find the dissection planes. Remember that the lower the refractive correction, the thinner the lenticle, and then it can be more challenging, which is why we say when you get started, start with a -4 and above. But again, with the Smile Pro laser, with the new Visimax 800, it actually makes those lamellar dissections much, much, much easier.
Completely agree. So, what happens if you have a difficult dissection? We've all been there. We phone a friend if we need, but it's really important to come in knowing some of your, rescue maneuvers. So, let's have Audrey play the video of her rescue maneuver. I think it's on the next slide.
Is it on the next slide? Okay.
So what's nice is, of course, you want to ensure that you've identified your anterior plane and then you've identified your posterior plane. But in the event that you go posteriorly first, what happens is that lenticule gets stuck up against the cap. And so it's going to be hard for you to then find that anterior plane. What you can use is called a rescue maneuver. So you use the Sinskey tip and you actually go into the corridor. That's going to be the space between the cap and the edge of your lenticule, and actually find the edge of the stuck lenticule and remake your anterior plane. So you'll see Audrey doing that here.
And so here it is. I dissected posteriorly first. All I do is with the tip up, Okay, you want to make sure that you're up, and you'll see how the spoon instrument then goes in. And so now I'm anterior. All right, and so I realized, oh, I dissected posteriorly first, not a big deal. And again, some people routinely do that. And then I'm just able to go ahead and get in with that little Sinski-like tip. And then you can go ahead and do that, get your spoon instrument in, and then get the lenticle out.
Another pro tip here is always make sure you check for the circular nature of the lenticule. I always open it up completely at the end of my case to make sure that I've gotten the entire lenticule. Because sometimes, especially in the lower myopes, the thinner lenticules, that lenticule is a bit more friable. It could potentially rip, and so you want to ensure there's no retained lenticular fragments. And especially if it's been a little bit more of a challenging dissection, you want to ensure that you've removed that entire lenticule in its entirety.
And the thing is, you shouldn't panic. If you do have a little tag left behind, it's really not a big deal. What I do is right after the lenticle removal, and I spread that out just as Nandini does, and I make sure it's a perfect circle. If it is not a perfect circle, you want to find out where it wasn't a perfect circle. And so it's really nice because you have that slit lamp beam. You've got that slit beam that's actually on the laser. So all you do is just for a moment, you look at your perfect circle, and then I like the slit lamp beam, and what the slit lamp beam does is it can show you the whole interface. So you just want to have a look, just make sure there isn't a fiber or something in the interface. If there is a little tag left over from your lenticle, you can identify where it is, and then you can easily remove it. To remove it, if there's a little tag there, you can just go in again with the spoon type of instrument. You see where it is, and you can loosen it centrally first, and then you can take your forceps and go ahead and remove the small, it's usually just a small tag.
Absolutely agree. So what are our pre and post-op regimens for our SMILE patients? I think very similar to what we do for LASIK or other laser vision correction procedures. Of course, pre-operatively, if the patient has any pre-existing dry eye disease, you want to optimize the surface. That's going to give the patient the toolkit to then treat any dry eye they may have after, but also give you the best possible refractive measurements prior to surgery. So we can do that in a variety of ways: topical immunomodulators, punctal occlusion, a short course of topical steroids. And then post-operatively, typically we're using prednisolone acetate for a little bit of a higher frequency for the first day or two, and then tapering down to about 4 times a day for a week or two. And then I also cover with an antibiotic for about 1 week at about a 4 times a day dosing. So minimal drop burden for the patient, and typically they're doing great by day 1. Most of my SMILE patients are seeing 20/20 by day 1, and I almost tell them it's like a fog lifting. They tend to see that almost incremental improvement each day, and within a week they're having really fantastic outcomes.
I also have them use the prednisolone or whatever your steroid du jour that you like to do more frequently, because we know that patients are notoriously not really as compliant as we want them to be. So if you tell them to use it every 2 hours, hopefully they're using it 4 times a day. Maybe they're really using it every 2 hours. Frankly, I doubt it. I think that they're using it maybe a few times a day. And then if you tell them to use it 4 times a day, maybe they're getting it in a couple times a day. So I purposely tell them to use it more than I know they really need it, because I know what people do. It's hard to use stuff several times a day.
Yeah.
And these are just some 1-day post-op SMILEs. You can tell they're just nice and clear. It's 20/20 vision there.
And things that you're looking for day 1, you're making sure that your cap interface is clear, your incision is sealed. If there was any epithelial disruption, you could even place a bandage contact lens on for 24 hours just to let everything settle. Also looking for any punctate keratopathy. If they have a little bit of dryness, advise them to use those artificial tears that they were already using from pre-operatively. So yeah, I think your patients will certainly look like this. It's almost hard to tell anything was done.
This is just another example here. We think it's another example. There we go. And again, just another example of, with the VisuMax 800, just how quick that is. And this is, again, real time. So it's that quick, and that's all it takes. And again, another lenticle dissection here. Again, about the Visumax 800, it's also a comfortable surgeon experience. There's less time for the lenticle creation as well as the dissection, less potential for suction loss, and a shorter overall surgery time, which means also you can have increased throughput of patients as well.
I think also for patients, verbal anesthesia is so important. Don't you agree, Audrey? I think it's really, I always like to educate my patients just for a few seconds prior to the procedure starting, whether it be in the pre-op bay that they're sitting in or right before they lay flat in the laser, just to know what to expect. Where is their fixation light? Where to look during the course of the procedure, what that very soft suction could potentially feel like. I think with the Visumax 800, you blink an eye and the procedure is done. But, in prior procedures that are up to 30 seconds, it's so important to counsel the patient, make sure that they know that they're doing a great job, where lights are going to go away, where they're going to see changes. That really helps avoid suction loss in your early cases, and I think it makes a very comfortable patient experience.
Absolutely. And basically, if you tell the patient your entire procedure is done with one laser, it takes less than 10 seconds, people can do just about anything for 10 seconds. And I think that makes them comfortable. It's like, okay, 10 seconds, that's it. And you're coaching them, but it's only 10 seconds. And I think that just leads to such a much more comfortable patient experience. A more comfortable patient experience, of course, Nandini, as we've discussed, leads to a more comfortable surgeon experience.
Yes. And that's critical.
Absolutely. And these are just some surgical times. This is the 800, of course, versus the 500. And you can see, just as we were talking about, just how much faster that is. Refractive and visual outcomes. And, the main difference, as we said, is the increased pulse frequency. And that's reduce the time that it takes to make the lenticle.
Mm-hmm. And of course, studies have just shown that incidence of suction loss is so much less with the faster laser times and the faster laser speed. I also think that, because of the ease of the lenticule dissection, you're spending less time in the eye, less chance of inflammation, faster healing, better postoperative recovery by day one, all very, important things to emphasize to the patient.
So then people always ask, what do I do in my practice? Well, if someone I tell patients, there's equal outcomes when we talk about SMILE, LASIK, PRK, no matter what procedure I'm going to give to you, we're going to correct your vision. It's going to be a safe procedure. You're going to have a great outcome. I choose the best patients for the best outcomes. If somebody is a equal candidate for all, then I do SMILE on them. What happens when do I do LASIK? LASIK is still a great procedure. There's nothing wrong with LASIK. It's a great procedure. If I have a very low myope, if I have really high cylinder, mixed astigmatism, or hyperopia, then I'm going to offer LASIK to that patient. PRK, I'm really not a huge PRK fan. I know some people get great results. That's excellent. I save that mostly for some enhancements or especially for refractive cataract surgery. Also, if they have a history of anterior basement membrane dystrophy, but I'm not a huge PRK user, but it's nice to have that in your armamentarium. I do also use ICLs if they're not a SMILE candidate and they have an anterior chamber depth of greater than 2.8, or if there's any borderline. I think if there's any borderline tomography or topography, then that's somebody that you don't want to do laser vision correction on. And I really don't think it makes a difference which laser vision correction procedure you choose or don't choose. If they're not a good laser vision correction procedure candidate, then they can do something else. I don't know, Nandini, is there anything else that you do differently in your practice?
Essentially the same thing. I've learned from the best. No, but I completely agree. And I think one of the most important things is to make a very firm recommendation to the patient. So, after you've talked to the patient, you've given them the options, you say, I think that, in my hands, SMILE would be the best procedure for you. Or perhaps you don't decide SMILE is the best procedure. ICL is the best procedure, and tell them why. And I think they really resonate with the opportunity to feel empowered to make that decision, but they know what it is that their surgeon is recommending. And I think that really helps with conversion to cases, regardless of the type of procedure that you're doing.
Yeah, I think that people, if you say, well, you could have this, or you could have this, or you could have this, that's very, very confusing for patients. I think you can say these are the different options for you, with your prescription, I would recommend this. We're going to get our best outcome, least invasive procedure, and this is what I choose for you. This is what I would recommend. And I think that that's the best way really of handling those situations.
Absolutely.
And as we say, the future is bright, and we want to wear non-prescription sunglasses. So
Awesome.
great.
Thank you.
Thank you. Thanks, everybody.
Any questions?
Oh,
So just a question on the post-op drop for the steroids specifically. Is it pretty standard? I know everybody's protocol is going to be a little bit differently, but would you say, generally speaking, a loading dose and then 2 weeks on the steroid after SMILE?
A week or two.
Okay.
I mean, that varies. I do that, and again, a lot of the reason that I do a loading dose and then just 4 times a day for a week or two is because I know patients are really not as compliant as we'd like them to be. So if I tell them to do sort of a loading dose of every 2 hours, I think maybe they're really getting it in 4 times a day. If I tell them 4 times a day, I'm thinking they're getting it in twice a day due to the studies on patient compliance. And that's why I do it that way. But that's really my rationale.
I'm very similar. I probably do every 1 to 2 hours the first day, and then I do 4 times a day, and then twice a day. So it tends to be fine, even if they're not compliant.
Yeah,
Yeah.
exactly.
Yeah. Cool. Thank you, guys.
Great. Thank you so much.
For more shows like the one you just listened to, check out the podcast channel on itube.net.